So having said that, there are a lot of ways that we do try and serve the health needs of immigrants. I'm going to talk a little bit about each of these. From a service delivery organization point of view, one of the foundational pieces is building our capacity to serve groups who are newcomers in our city. And we have, as a part of building that foundation, a mandatory training program. We put everyone who works in Toronto Public Health through a 2.5-day intensive training program on access and equity in order to better prepare them to both understand and confront the health challenges faced by people who are new to the city and are part of the city's diversity. Now, we know from talking to immigrants that they face a number of barriers to service. So some of the things that we do to try and reduce barriers to service have to do with access. Most health services, hospital services, physician services, are not available for the first 3 months for people who are landed immigrants in Ontario. That's also true in BC, but not necessarily across the country. This waiting period is a significant barrier to service. And of course, health services are not supposed to be available for undocumented newcomers. All public health services, in contrast, are available, and we try to make this very clear. This is an example of an outreach card aimed at informing settlement workers about public health services, and it's very clear to say that you don't have to have Ontario health insurance to be served, and it doesn't matter what your immigration status is. The impact of cost is something that's important as well. You know, we think of ourselves as living in a country which has universal, publicly funded health care, but of course there are many forms of health care that you do have to pay for, and in particular pharmaceutical products and dental services. We have a series of dental clinics across the city which provide free dental treatment for low-income children and seniors that are heavily used by our immigrant communities. And we know that recent immigrants are nearly 3 times more likely to have not seen a dentist in the past 3 years compared with people born in Canada. For health services in particular, communication is absolutely critical. In order to be able to talk about your health problem and receive advice and input, there needs to be effective communication. Public health services are accessible in Toronto through the municipal 311 telephone service, which is capable of translation in 180 languages. And we do the best we can to try and provide language-appropriate materials and direct interpretation for one-on-one professional services whenever possible. During last year's H1N1 outbreak and the response that was mounted in terms of immunization, all of our materials are translated into 18 languages. Now, clearly we have a lot more to do in this area, and there are real cost implications, but linguistic access is not enough. Health is very culturally context sensitive. People bring with them their health beliefs and understandings and practices from their country of origin. So when we're designing a program to try and influence health, we have to take into account the cultural context. This is an example of a program for breast health and breast screening for Somali women, which was developed in partnership with the Somali community in order to ensure that its context is appropriate. We adapt our programs whenever possible to specific immigrant groups. Diabetes is a major challenge in many newcomer communities, both on arrival and over time. This is an example of a component of our diabetes program which is specifically tailored for immigrant communities. We need those communities to see themselves in these campaigns so that they'll understand that they're tailored for them. Many public health programs are focused on children because that's the opportunity you have to influence health over the entire life course. We offer a number of different types of parenting programs because of the role that parenting skills play in successful child development. But what if your family has been separated over many years through the settlement process? This is very stressful. Children are often reunited with parents who they may not have seen for years and hardly know. So this past year we developed a specific parenting program for families going through the reunification adaptation process, which addresses mental and physical health problems and parenting skills for immigrant families who have been separated and reunited. We work to do this with settlement agencies to take advantage of their expertise in family reunification. And one component of the program is a support group, for example, for newcomer youth to help them in the settlement process to build positive relationships with their parents. You've heard me mention partnerships a number of times in describing these initiatives, and we do think that that is absolutely key to ensuring the effectiveness and appropriateness of public health programs. We have many, many partnerships in both program planning, development, and delivery. In some cases, particularly in the area of HIV/AIDS and drug use prevention, we fund community agencies directly through grants to build their capacity to serve their own communities and to partner with us. We also advocate in conjunction with community partners for service access and healthier public policies that would serve the needs of immigrants. Here's an example of a community partnership. This is also a diabetes program which was designed in partnership with 16 different local non-governmental organizations in order to address diabetes risk in immigrant communities. Another strategy which we have found very effective is to use a peer model to formally integrate community members into the process of service delivery. This material is for a family home visitor program which is delivered in 35 different languages and cultures. We hire community members from immigrant communities for their cultural and linguistic capabilities and their settlement experience to work alongside with professional public health nurses to provide pre- and postnatal care for moms and babies. And we recognize explicitly that both components, both the professional clinical component and the cultural knowledge component, are absolutely essential to ensure an effective outcome. Another program which uses this approach is a peer nutrition program in which we hire and train peer nutrition educators to work alongside dietitians to ensure that newcomer families with young children learn how to navigate our food system and provide nutritious and affordable food for their families. Now, these programs are not explicitly settlement programs, but what we find is that very often families will come to a food program or a nutrition program when they wouldn't necessarily go to another kind of settlement program. So we end up surfacing a large number of settlement issues at these programs, which are not necessarily core to the program, and end up making referrals and connections in that way. So it's kind of a stealth settlement program. I'd like to close by coming back to the issue of information. In order to reduce health disparities and address the health needs of immigrants, we really need better information about immigrants and their health status. Much of routinely collected health information, whether in hospitals, doctors' offices, communicable disease reporting, is collected without any information about immigration status. That needs to change. In the absence of that, we resort to some fairly complex methodologies for record linkage between immigration data sets and health data sets, which gives us something to work with, but we should be increasingly building in the collection of information into all sort of normal health data sets and also in service delivery situations. So to this end, we're piloting a data collection tool which will ask clients in some of our programs about 9 aspects of socio-demographic identity, including immigration status. We need to learn how to do this in a way which doesn't create additional barriers for clients of our services, but at the same time gives us information in which we can use for better service planning and to evaluate the results of our efforts. So I'll just end by saying that our goal in all of this work is to get to the point where the next time I make a presentation like this, it starts with this slide. Thank you very much.